All right. So around Thanksgiving, we were able to do a couple of podcasts where we had a discussion with my father, who was a former homicide detective with the LAPD. And now, just in time, well, probably right after Christmas, I wanted to be able to do this podcast with my mother, Robin, who has been a nurse for, well, I'm not going to say how many years because she'll throw something at me, but has been a very accomplished nurse, both in the United States and abroad in the missions field. And we're going to talk a little bit with her today about some of her experiences being a nurse during COVID, some of the craziest stories that she has either, lived through or experienced, and also some of the things that you need to know. Like what are some of the medical skills you need to know for a variety of conditions? We'll discuss surviving the zombie apocalypse, because let's face it, if you don't know how to do basic first aid, the zombies are going to get you. I've seen Walking Dead. I'm somewhat of an expert on this, and we all know that'll happen. Plus, having worked, for decades now as an OB nurse, she's going to answer the age-old question of, what do you need to know as a guy right now to deliver a baby in a survival situation, having only a pocket knife, a handkerchief, and AC/DC's greatest hits, right? So all of that will be answered on this podcast, brought to you by Good Ranchers. Okay, so Robin, or as I prefer to call you, Mom, thank you for being on.
Thanks for having me here.
All right, well, okay, so Are you comfortable telling the audience how long you have been a nurse for now?
About 45 years altogether.
45 years as a nurse, and that's been like multiple obviously not just at one hospital. You've worked at multiple hospitals. You've worked overseas. What got you into nursing in the first place? What made you want to be a nurse?
Well, I was always interested in medical things growing up. And then when I was a senior in high school, 17 years old, oldest of 4 kids, and we didn't grow up wealthy. We were, rather poor. Yeah. My dad suddenly became very, very ill and was in UC Davis Medical Center. We actually didn't know if he was going to live or die. And so I walked in and found out I had enough credits to graduate from high school, so I did. And I took turns trading off with my mom, taking care of my little brothers and sisters, and then going down and staying with my grandmother and helping take care of my dad. And that's when I decided, I thought at that time, do I want to try to be a doctor or do I want to be a nurse? And I saw what a difference a nurse could make and how a patient felt and just the little things that they can do, along with obviously some of the major things. But that's when I decided that I really wanted to be a nurse. And so I graduated. I had already graduated, and right after my dad got out of the hospital, and he survived, thank goodness, I went off to nursing school. Started out in college, got into a nursing program, and proceeded from there. I ended up in the middle of my education, getting married, having a baby, who was sitting across from me now. See, you interfered in my education. Actually, I had just been awarded a scholarship to study, a full-ride scholarship to study in a foreign country. Then I found out they were going to send me to Cali, Colombia in the late 70s, early 80s.
Oh, yeah. What could go wrong? Yeah.
What could go wrong with that, right? Here I was, this naive little blonde, tiny, 100 pounds soaking wet little
So
gal.
were you going down there to study nursing or Spanish?
Both.
Okay,
yeah.
so you missed out on being Pablo Escobar's nurse because of me.
Yeah, probably.
My bad.
I think, son, you probably saved my life.
Well, I do what I can.
Thank you. So anyway, I ended up getting married instead and having this baby, and then going back to school. When you were 3 weeks old, I was back in school full time and working full time.
So were you working? So at that point, you weren't a registered nurse.
No,
yet.
I was working as a nurse's aide, nurse assistant. Yeah. I went through a quick program and finished getting my LVN, which is kind of a step up from just being a nurse's aide. That's a licensed vocational or licensed practical nurse. And then from there, your dad and I moved down to Southern California. He was hired by LAPD, and I got to finish my RN down there.
So what are the different levels of nursing? Like when you go into the hospital, obviously, like we've all kind of heard of like the candy stripers or whatnot.
Those are volunteers.
Volunteers that are helping. Mm-hmm. So what are the candy striper, volunteer, helping out.
Yeah.
How does it go up?
Then there's a certified nurse's aide.
Okay.
And these are ones that bring you water, take your vital signs, change beds, things like that. Then the next step up is LVN or LPN, depending on what area of the country you're in. And they are licensed and able to give medications, start IVs, do a number of things, dressing changes, things like that. Then above that, our next step up would be a registered nurse. And you used to be able to be a registered nurse after before you actually got your bachelor's. Now they're recommending everyone get their bachelor's degree along with it.
Higher ed wants their cut.
I suppose, you really need art appreciation to be a nurse, but hey, it doesn't hurt.
Yeah.
So anyway, next would be a registered nurse, which has a lot more options of what you can do, areas you can work in, things you can be trained for. After I got my RN, I went to work in an intensive care unit, and they started an open heart surgery program, cardiac ICU. And so the patients that would have cardiac bypass surgery, things like that, would just come up the elevator right into our ICU, and we would take it from there.
Well, let me ask you this question: where does nurse practitioner fall in?
That's an additional training beyond registered nurse, and they often work at a doctor's office. They'll see patients that come in instead of the doctor seeing absolutely everybody, but they work under a doctor's license.
Okay,
still.
so let me see if I understand this. So when you're an LVN or LPN, so you're considered a nurse at that point? You're a licensed nurse, but would you say that what most people think of as a nurse when they go in the hospital is the registered nurse? Generally
speaking, I would say so.
And registered nurse. So if you're an LPN, you're kind of limited on what's the difference on the limitations on what you can do from an LPN to an RN?
Well, LPN is usually not in charge. Usually a registered nurse is in charge. Registered nurses can do other procedures, assist with more complicated procedures. They can give IV medications.
Okay.
An LPN, LVN doesn't normally do that. They can give IV fluids, but not IV medications.
And so when you're in it, so you talked about the first thing you worked in was ICU, so the intensive care unit. So these are people that are they in critical condition but stable, or how does that work?
Sometimes not so stable.
How do you get to the ICU? Right?
It takes a lot of extra training. So when I actually had started working in an ICU when I was an LVN back in the day, back a long time ago, you could do that. You couldn't do as many things as the RNs, but there was a lot that you could do. So I had started there, so I was familiar with a lot of the things around the ICU. And there are different types of ICU. There's a cardiac ICU, trauma ICU, like a medical surgical ICU, where you would take cases of more complicated surgeries that come out and they come to your unit.
Okay.
So there's different variations of that.
So how long did you work in ICU for?
Several years.
Now, what did you like about ICU? Did you want to go to ICU?
Very much.
Okay, so why?
I still miss it.
Yeah.
I like ICU because you have one or two very critical patients that really need your full attention, interventions, medications, lab work, things that constantly need to be done that you're watching for. In ICU, with cardiac ICU, I had learned how to use what's called an intra-aortic balloon pump. We put in Swan-Ganz catheters in just about everybody back in that day.
Yeah. What is that? Talk to me like I'm 6.
Similar, the most simple way I could put it, it's like an elongated IV, I guess you'd say. It's like a little tiny catheter that goes threaded through a person's vein and goes around and actually sits in the heart and gives you information about the pressures.
Wow.
The pressures, the blood passing through the heart, things like that. Can also give you information about oxygen levels and things. I have not worked in cardiac ICU for several years now, so I am certain that there are many new things that I am not aware of.
So you worked ICU for several years. What were some of the other? What's the proper terminology? Would it be departments?
You can say departments, sure.
Okay. So you worked ER for a little while, right?
Just a little bit.
All right. Did you not like it? Because so obviously when we're looking at the TV shows, right, about hospitals or whatnot, they're usually always focused on two areas within the TV shows, maybe three, but it's surgery, right, and the ER, right. That's so you worked ER for a little bit. What do the movies get totally? I'm sure they get a lot of things wrong, but is it everyone just running around going, "I need this stat," or
a lot?
Yeah,
there is a lot of that. It's funny when you do watch a program that's a medical type program, and you see things that are done. Usually, they have pretty good advisors, and they try to be very accurate. But every now and then, you'll see like someone that's supposed to be a doctor playing the part of a doctor, listening to someone's heart, and they forgot to put the stethoscope in their ears. Or little things like that every now and then you kind of chuckle about. But there are times when I've been at work and I look for the cameras and I'm thinking, I must be on a TV show. Where's the camera? This is just too wild to be real.
Would you say, so you've worked ICU, you worked ER for a little bit, and you worked OB for
Quite a while. Just coming up on 30 years here.
30 years in OB. So that's been kind of the main. So we're working delivering babies, right? So here's my question: out of those three, were there any other departments that you worked?
Actually, one of my very favorites was Trauma ICU.
Okay, Trauma ICU,
and that was fantastic. I think the reason I liked it so much is because the place that I worked at that time, we had such an incredible team of nurses, doctors, such a cohesive group working together that it was amazing. I always had told people, if I'm ever in a car accident or any kind of an accident, I don't care where I am in the country or in the world, get me here.
Yeah.
And it's nice to feel that way about the place that you work.
Now, would you say, so I'm going to bring this back to Hollywood just a little bit because that's the frame of reference for a lot of people. Either they've been in the hospital or they watch something on TV. And a lot of times in the TV shows and whatnot, you get this like almost kind of strange dynamic between doctors and nurses. Mm-hmm. And the only way I could kind of equate it sometimes, even though it's different, but if I had to equate it to something from a military experience, you have the NCOs and you have the officers, right? Uh-huh. And the joke among NCOs, especially senior NCOs, was they think they're running the show, and we think that's adorable, and we like to let them think that. But obviously we respected each other's roles and what we did. Is there as much tension between doctors and nurses in real life as you see kind of on TV? This has been a very interesting conversation, and it just reminds me that I want to stay out of the hospital. And one of the best ways to do that is to eat right. And if you go to goodranchers.com and use promo code Nick, you're going to get 15% off a whole lot of right. That's right. They've got the best American-raised beef, poultry, pork, and wild-caught seafood. Not to mention the fact that you're going to get 15% off all kinds of gifts that they have available. That's merch. That's boxes of meat. All of it, all the way up until December 31st. Because let's face it, some of you did not get presents in time. But Good Ranchers is there to make sure that you're squared away. So goodranchers.com, promo code Nick, 15% off, gift boxes. There's merch opportunities. There's all kinds of stuff. Go check out the website, get the discounts, 100% satisfaction guaranteed with goodranchers.com.
It depends on where you work. Okay. Hospitals tend to have personalities. Even units, ICUs, different units tend to have a personality. Some of them work like clockwork, and some of them there's a lot of angst going on. Most places I've worked, there is definitely a hierarchy, with the doctors and the nurses. And, as there should be to some degree, I suppose. But most of the time we get along pretty well. I think they understand that we're their eyes and ears when they're not there. Mm-hmm. And honestly, they're not there very often. It's us.
Do you find that new doctors can come in a little bit cocky and maybe not respecting the role that nurses play, and then over time, or do they come in kind of knowing they don't know as much as they think they do?
It depends on the individual, yeah. I've been in code situations, and the resident runs in, and you can tell they're looking for the ICU nurse, like, help me. And then others are very competent, and they do an incredible job. And it depends if they're in an area they really want to be in.
Okay.
A lot of, you say new doctors, a lot of times that would be a resident, someone that's already graduated, they're a doctor, and they're going through different residencies, more or less to figure out exactly where they want to work.
So when they say residency, that means that they can, depending obviously what they studied in school, I assume, they do residencies in different departments to kind of figure out where they're going to specialize? Or they
may have already decided and they're doing a residency in that particular area.
And that's called in practice, right? When they get to...
I suppose.
Okay. I wasn't sure what the level...
I've just always thought of it as residency.
Okay. But, I'm trying to figure out the doctor rank structure.
You're right. Well, there's always the doctors that are experienced that have been there for a long time. So you're working in so Trauma ICU was one of your favorites to work, and you had a really good dynamic there with the other nurses and the doctors and whatnot that were working in it. And so it's interesting that you say that hospitals will have kind of a personality. What do you elaborate on that without obviously mentioning any, because this is the other thing people need to understand. For anybody that knows you right now that might watch this and be like, wait a second, is she talking about our hospital? You've worked at a ton of hospitals. I worked at so many hospitals in different states. I've been a travel nurse, which is a little different. You go and you're a temporary employee, usually for about 3 months on average.
When I remember when Tina and I were still in the military, and Tina, you would oftentimes, get a travel job so you could kind of be close to us, and help out whether because I might be deploying or I might be in the field for several weeks at a time and whatnot, and that was something that was always really appreciated by us. So I want to make sure everyone understands you've worked all over the country, so
correct.
But when you say a hospital, sometimes a hospital or a department can have its own personality. What do you mean by that?
Sometimes the personality, I think other nurses would understand this. Some hospitals, people just get along. The coworkers, mostly women, and especially in the OB department.
Okay.
It's mostly women. In ICU or emergency room, there's a lot of guys that work there too that are RNs. But it just depends. It's hard to explain. Sometimes it's more like a sisterhood. You're all like a group of sisters, and sometimes you bicker a little bit like sisters might. But boy, you stick up for each other. You've got each other's back.
Well, let me ask you this. So would you say that a hospital kind of have its own personality? When you look at an individual department, do you think either the senior doctors or maybe the charge nurse or the senior nurses, do they really kind of set the tone for the personality of the department?
Yeah, they definitely can.
Yeah, and so and just so everyone in the audience who might not be felt like a charge nurse would be kind of the senior the head the nurse in charge for that shift or that department. Is that an accurate?
It would be for that shift, the PM shift. If it's an 8-hour shift, like the 3 to 11, there might be someone who's the charge nurse. In a smaller hospital, they will also probably have a patient assignment. In a larger hospital, they probably won't.
What does that mean?
Well, it means that in a larger hospital where you have lots of patients, lots of nurses on a floor, the charge nurse has to oversee everything and make sure everything is running smoothly. If they're getting admissions or transfers, they have to coordinate all those things. They have to make sure everything is going on and rolling along as it should. So it's not really possible for them to have a patient assignment.
I gotcha.
As well.
So they're kind of managing.
Correct.
Managing things as they come in, but it's not like they have their patient that's their patient that
Correct.
Okay.
But in a smaller hospital, you do.
Yeah.
I've worked in both, and in a smaller hospital, you might be in charge and trying to figure out, comings and goings of different patients and assignments and things. Maybe a nurse has to go home sick, and now you've got to figure out, what am I going to do? Can I call someone in?
Yeah.
But in the small hospital, you will also have your own patients to take care of as well. So
So you're not just
keep
making
you pretty busy.
Yeah, you're not just making sure the trains run on time. You've actually got specific patients that you got to be assigned to at the same time. Okay,
that's true.
Well, let me ask you this: from the so you had cardiac ICU, trauma ICU, ER, OB. Would you say those four were kind of that's
the
primarily
main ones?
Okay? So let me ask you this. Well, and I'll break it into kind of three: ICU, ER, and OB. Obviously you've got to be careful of, patient confidential and all of that, but I mean, there obviously, you can read the news and you can hear about harrowing medical stories and things like that. So let's say from your ICU days, what is, and even if it's not a specific, case, but like, what is something that kind of like walk us through a day in the life of, maybe a scary day or a happy day in the ICU? Like what's a day in the ICU where it's like, yep, that defines what that experience is like?
Usually it would be a code blue.
Okay. So what does code blue mean?
Code blue, it's called different things, different places, but code blue is basically a cardiac arrest.
Okay. So you have somebody.
It can be caused by a number of things.
And I'm assuming if you're in the cardiac ICU, it's probably, a heart attack probably brought you in there, right?
Possibly.
Okay.
Yeah. Or cardiac bypass surgery, something like that.
Okay, so all right, so somebody
the preemptive strike to having the
okay, so somebody is a patient that's high risk, and cardiac related. So they're in the cardiac ICU, and then all of a sudden code blue goes off. What happens next?
Well, you call the code blue. Sometimes in a cardiac ICU, you don't necessarily call it overhead, but there's usually a button or a cord you pull or something like that. And then the other staff in the unit will show up, come on in there and help you. You start CPR, you do cardioversion if necessary, give the cardiac drugs that are needed according to the type of cardiac arrest that it is.
Well, how do you know? Like, so I'm imagining a situation where, again, you've got things are relatively calm, people are around, you guys are doing what you do under normal circumstances, and then all of a sudden, like, what happens when code blue? Like, are blue sirens go? Like, what's going on? What's going on in there when code blue goes off?
Usually it's like a sound, like an alarm is going off. Okay. And then like the light outside the room might be flashing to show you where it is.
When you say based off of the cardiac arrest, like what do you mean? Like, because I imagine you're running in and it's not chaos, but a lot of excitement.
They go into, usually it's what we call VFib, ventricular fibrillation, which is the heart is just fibrillating. It's just kind of vibrating. It's not putting out any blood.
Okay.
So technically, you have about 4 minutes of the brain without oxygen and the organs without oxygen before there's permanent, irreversible damage.
So what are the other forms of heart attack?
Other forms would be just asystole. The heart just stops. It blocks out. Okay. Something happens, a blood clot or something, and it just blocks the pathway, the electrical pathway that causes the heart to beat in order, and it just stops. And then you have asystole, which is a real bad one. Most people don't come back from that. Or you can have a rapid VTAC, where the heart's beating so fast that it doesn't really get enough cardiac or enough perfusion to get the blood out to the major organs and particularly to the brain. And then again, you've got about 4 minutes to try to restore that circulation and oxygenation to the brain.
See, I'm revealing my own ignorance here. When I hear heart attack, I think, oh, my heart just stopped. But there's multiple versions of heart attack where it can either be moving too fast or not at all, or
correct,
just not sending the right signals to actually, or irregularly. I've obviously we've heard of like an irregular heartbeat or whatnot, and all of that stems from the idea that if it ain't working right, blood isn't flowing the way it's supposed to be, brain isn't getting oxygen, so you would say that in most of those situations, it's all about like what do you. Because again, I think the image in most people's minds is you guys are all running in with like paddles and clear, boom.
Kind of.
Okay.
Yeah, that happens.
So that's a pretty accurate depiction of.
Somewhat, yeah. You know, in an ICU, you're a little more prepared for the possibility that that's going to happen. But yeah, it's an intense situation no matter what. Even if you're well practiced at it and you've been through code blue a number of times.
Yeah.
It's still an intense situation because you're fighting against the clock and you've got to get circulation and oxygenation restored within a very short period of time.
Go ahead.
Yeah, I was going to say it's different in the hospital setting than it is, say, out just anywhere. If you're just out like on a baseball field or out hunting with your friend or something and someone collapses, there are different reasons that people have heart attacks or need like emergency code blue assistance. Sometimes they might be bleeding out.
Yeah.
Sometimes they've had an electrical shock. Sometimes there can be just almost anything that can cause a situation like that.
So I imagine what happens is you're in cardio ICU and you've got like how many patients typically might you have and I realize this probably varies based off of a big hospital or a smaller hospital, but like at a bigger hospital, we'll go with that. Mm-hmm. How many patients do you probably have assigned to one nurse?
In a cardiac ICU?
Yeah.
1 or 2.
1 or 2.
Now, I've worked in hospitals in certain states where they do not have the legislation to back up the staffing. They don't have particular staffing laws. And I've seen where, you've got more patients in an ICU, which is, I think, not a good situation in most cases. But usually it's 1 or 2. If you get somebody that you're receiving someone back from cardiac surgery, then you better just have that one patient.
Yeah.
If they're stabilized and, it's the next day, sometimes you'll have 2.
Yeah.
Same thing with a trauma ICU or a medical surgical ICU, things like that. You would usually have 1 or 2 patients depending on how critical they are.
So wait, one or 2 nurses per patient, or
if they're on an intra-aortic balloon pump that we used to do, there would be 2 nurses to that one patient.
So that's per shift, 2 nurses per
right.
shift. So why 2? Why 2 in that situation?
One nurse has to run the balloon pump.
Oh, okay.
Yeah. And like I said, I haven't been in
they might.
in cardiac ICU for a long time. They may be doing something a little bit different now.
Okay.
But
what about trauma ICU? Because trauma ICU, again, I'm thinking in my head, gunshot wound, or pretty much anything. Somebody could have gotten a bad car accident. Motorcycle versus deer. Oh,
I've
really?
had some real interesting ones. Sometimes we've had people on those rotation beds that you see in the movies where you flip the person over.
Oh, yeah,
It's like a rotation. I don't know how else to describe it. It's like a cage type of a thing, I guess, for lack of a better description. And you can roll the patients, so they're prone, so they're face down or, sideways, or just change their position just because of the framework that they're in.
Yeah.
And a lot of times you're giving massive blood transfusion.
Okay.
And that requires a lot. Sometimes 2 nurses, one to run and get blood and bring it back. And you're not just giving blood, you're giving, plasma and cryoprecipitate and platelets and all kinds of things. Some of those things need to be done a little bit differently than just a standard blood transfusion. So there's a lot going on.
So a lot
of times with those patients. And at the same time, you've got to be carefully monitoring vital signs and heart rate and blood pressures.
Let me ask you this, because it sounds like, the very, very limited medical training, I went through in the military, and our 18 Deltas, they went through a lot, and they focused a lot on trauma because that was kind of our job. But here's my question. In a cardiac ICU, I would think, and correct me if I'm wrong, but I would think that in most cases, when you got to go running into a room, you know what you're running in to deal with.
Pretty much. But you can see it on the monitor. Okay,
but in a trauma ICU, it could be any number of things, right? Obviously they got brought in for a particular reason.
Right.
But
they would generally hit the emergency room first, and then we would have some knowledge of what happened. They were in a car accident, steering wheel trauma to the chest, or whatever. We would know by then, if they had lost a massive amount of blood, if they were conscious or unconscious, if there was a head injury involved. That's another area would be neuro ICU, which I never really worked specifically neuro ICU, but you do get some of that in trauma ICU, of course. So we did have to have a reasonable knowledge of that too.
So what were some
intracranial pressure monitors and things?
Got it. So what were some of the craziest traumas that got people landed in trauma ICU?
Oh gosh, all kinds of things. Like I said, deer versus motorcycle.
Is that a common thing?
I don't know about common. We had a few of those. People out on those ATVs and rolling them and being thrown, car accidents, drownings.
Would you say that
gunshot wound?
Yeah. Would you say that some like vehicular accidents were the most common thing that would usually land someone?
Generally speaking, yeah.
Okay. Any ones that are just like bizarre?
Oh, let me think for a second. Of a vehicle accident?
No, just any bizarre trauma. It's,
I knew of one once. I was not involved in this,
Okay.
but I heard about it later.
Yeah.
And patient presents to the emergency room with a huge butcher knife protruding out of his chest, a self-inflicted wound. He put it up against the wall and ran onto it trying to commit suicide. Well, he was still alive somehow.
Oh my gosh.
Well, here's the other thing too. If you have a major trauma with like a stick or a limb or a knife or something in you, don't take it out.
Okay, that's good to know.
It may actually be tamponading or stopping the bleeding. So just get to the hospital. But anyway, this fellow was still awake, and the doctor at the time, there was a vascular surgeon there, they pulled this guy in. I don't even know if they did this in the ER or the OR. And he split open the guy's chest, got in there, did a couple of quick stitches in the heart,
So he did hit his heart.
Yeah, he did.
Wow.
And they took him in, and then they to stop the bleeding, get everything together. He threw a few stitches in, and then they hauled him into the OR and, then finished the job correctly. I saw the guy with my own eyes a couple days later up walking in the hall.
Oh my gosh.
Just amazing. Yeah, that was pretty remarkable.
Do they have
That should have been on a TV show.
Oh man. Well, yeah, you don't imagine.
You don't see that every day.
No. Well, and especially like as far as someone, that's horrible when somebody, attempts suicide, but the way he attempted it, oh my gosh.
Usually people that do things violently like that succeed.
Yeah.
So that was a pretty rare case. Hopefully he got plenty of psychiatric counseling and things too to, keep him from doing that again.
Well, speaking of that, there's something else too that I think people should understand, and because this blew my mind. And I remember my good one of my best friends in SF, Mike, and his wife Casey. She was a nurse, and you guys were nurses together for a while.
Yeah,
I remember one time Casey talking, and this is something I don't think people realize because I didn't realize it at the time, but I think it was it Tylenol? Let everyone know because there are cases where someone is doing like a cry for help.
Yes.
And because it's over the counter, they think this isn't a big deal.
I've known of a number of cases.
Yeah.
Not too many, thank goodness, but a few, where someone will take a large amount of Tylenol thinking, well, Tylenol's harmless. And then they'll go sit in the emergency room parking lot or go into the emergency room a little bit later. The problem is they've just succeeded in committing suicide. So maybe they were, like, as you say, it was a cry for help. They didn't really mean to. Tylenol is absolutely deadly to the liver. It destroys it. The problem is it will be a slow and painful death, and there is nothing they can do to save you short of a liver transplant, and you're probably not on the list.
Yeah.
There are people that are waiting for liver transplant for months and months and months that don't get one.
Yeah.
And somebody that tried to commit suicide like that is probably going to be pretty low on the list, and they won't get one in time. As a matter of fact, a dear friend of mine, her sister was doing that kind of thing, kind of the cry for help, like, oh, look at me, everybody, and I need some attention. I'm sad, I'm depressed, I need help. And she took a bottle of Tylenol PM, and about a couple weeks later, she died. And it was horrible, and her sister was just distraught over it and is now raising her child.
Wow.
And it was heartbreaking because she didn't really want to commit suicide.
Yeah.
As you say, cry for help, and there's a lot of things like that.
When I remember that, her explaining that to me. She goes, yeah, it's horrible to have to explain to somebody that did something like that, thinking they were going to, just wake people up to their problems or demonstrate that they were having a hard time.
Exactly.
And then you have to explain it. It's like, okay, like you said, you succeeded. It's probably going to take, several weeks, and there's nothing we can do about it. And it's just kind of the horror of someone realizing that they really didn't have any intention of actually following through. And now for several weeks now, they're going to get to contemplate this. And it feels like it should be something that we can fix.
You would think, but it's not.
Is there any other like over-the-counter stuff like that people don't realize how dangerous it is?
Probably.
Yeah.
I can't even, actually, you can overdose on vitamins and cause some serious harm depending on what it is. But I'm sure that there's a number of medications. If you took too many of them, it's gonna succeed in your demise.
Yeah. Well, I working ER, you said you didn't work ER long. Why did you not particularly like ER?
Well, I'm a very practical kind of person. And, I was pretty sure if I worked ER for very long, I would get fired.
Okay.
Because
well, that's interesting.
Probably because of the number of people that come to the emergency room, basically wanting a sandwich and watch their favorite TV show or something like that, or they'll come in for very minor complaints. They've got a cold or a sore throat or an earache or something very small.
Yeah.
That come on, you could have gone to Walmart and bought some cough drops or a 98-cent bottle of Tylenol.
Now, are you required?
Just don't take it all.
So, like, I know with EMTALA laws, and most Americans don't understand this. They watch the Hollywood version of American healthcare, and they think that the hospital just kicks you out because you can't afford to pay. When it's like, no, that's illegal. That's illegal.
Is illegal.
In the United States, you are guaranteed health care.
Yeah.
They have to, at the bare minimum, stabilize you in order to transfer you to another hospital. Yeah. But there's no such thing as you just dying because hospitals refuse to provide care.
Correct.
And what it equates to is hospitals are one of the only industries in the United States that are required to give you goods and services regardless of your ability to pay.
Correct. And we do it all the time.
So let me ask you about that, because there's a lot of people that will look at something like this and be like, well, of course you would. And I don't think anybody doesn't want people to be able to get healthcare when they're in, a dire situation or a life-threatening environment. But what you're saying, and believe me, you're not the only person that I've talked to that has worked ERs that have come to this conclusion, is that there is a lot of people that exploit that law and that system for what you just said. So let me ask you this. It is one thing to tell a hospital that you are required to make sure that, somebody doesn't, they weren't just shot, or they don't have, they're not right on the verge of having a heart attack or something like that, to where they will need. What you're saying is that somebody is walking in, and are these like what we might call regular offenders? Like, is it?
Some are.
Yeah.
Yeah. And they can come in and get care, get it. If they say, the right buzzwords, like, oh, I have chest pain. Yeah. They come in, they get, cardiac labs drawn, they get an EKG, they get a chest x-ray, they get put on a cardiac monitor. Yeah. We watch them for, oftentimes several hours. Yeah. And then everything's fine. You haven't had a heart attack, you're good to go. And we can discharge them. They can turn around and walk right back in the door and make either the same or another complaint, and we are required to treat them.
You have to go through the same process again.
We have to treat them.
So it's not like you can say, hey, look, we just did this. We're not taking up a bed. We're not taking up an EKG monitor. Nope. You have to do it all over again.
We have to treat them.
See, this is the part I don't think people understand, is that this happens, and that this happens on a fairly regular basis on ER department or in ER departments all across the country. And what that equates to is that doctor's time, that nurse's time, the use of that equipment, the use of that bed. And so people will look at an ER visit. They'll look at an ER visit and they'll be like, I'm furious that I had to wait, 2 hours to be seen. And then when I finally got a bed, they didn't do anything. And as much as I can understand how frustrating that is, I can imagine it's even more frustrating for the nurses and doctors who see exactly what's going on, can pretty much effectively differentiate between the people taking advantage and the people that desperately need to be seen, and being told, sorry, federal law says that if we want to be able to take Medicaid patients or Medicare patients or just exist as a hospital, we have to provide these services, and we can't tell someone who's obviously manipulating the system, we'll see you tomorrow. Like not even we'll see you tomorrow. It's like, nope, they came in the same day. Okay.
No, I had a patient in the waiting room once in an emergency room, and he had a very significant gash in his arm, and he's like, we've been waiting for 6 hours. And I apologized to him profusely. I said, look around you.
Yeah.
Do you see, these people sitting here reading magazines, the kids running around banging on the Coke machine, tearing the magazines up, all that. These people are here. They could have gone to Walmart and probably bought maybe some cold medicine and, not all of them for sure. There might be other things going on. I don't know everybody that's sitting in the ER waiting room at that time.
Yeah.
But here was someone who very obviously needed to be seen. And we try to triage people as best we can. He wasn't bleeding to death. He wasn't having a heart attack. Excuse me. So, he just had to kind of take a number and wait, so to speak. And I just try to explain to him that this is such a common problem.
Yeah. So let me. I had somebody local who was an EMT told me that during COVID, somebody called an ambulance because they wanted to go get cigarettes. Now, obviously, they didn't say that over the phone.
Yeah.
But
I had a patient call me up in the OB department and say that her mother-in-law forgot to pick up some Tylenol for her. So she was going to call the ambulance to bring her to the hospital because she wanted some Tylenol. And I told her, do not do that.
Yeah.
Do not call an ambulance. You can find someone. I was like, where do you live?
Yeah.
And she lived about 3 blocks away. I said, get someone to walk down there and get it for you. Or if you're not in serious condition, walk there yourself. Sure enough, she called the ambulance to get a Tylenol.
And never paid for that because.
Oh, no. Yeah. What is it? $1,000 or more for an ambulance ride?
Well,
we paid for it.
Yeah. Everyone with health insurance paid for it. Everyone that pays taxes paid for it. But
and I've had a patient come to the OB department, come to the emergency room and get sent to the OB department 2 days in a row because she needed some cough drops. She had kind of a sore throat and wanted.
And you guys are required by law to give them medication.
We are. That one I thought I was going to get fired over because. Excuse me, I confronted her and said, do you mean to tell me? I mean, we saw you yesterday. We, gave you medication. We got you a prescription. We saw you. We checked out your baby. Everything is fine. And yet you came back today to the hospital because you still have a sore throat. It's like, seriously, can you not afford to go to a local drugstore or Walmart or wherever and buy a 98-cent bag of cough drops? Oh boy, was she offended. Called her grandmother. Her grandmother came down, stared at me. I thought if she could kill me with looks, she would. And I couldn't believe it. So I went to my purse and I got out $5 and I brought it to her and I said, honey, if you truly cannot afford to buy a $1 package of cough drops, I will buy them for you. Yeah. I don't want your money. I don't want your money.
You are getting my money. You're just holding up the hospital at the same time.
Right. No, I said, a hospital visit like this is approximately $800. I feel badly if you truly. And she was dressed nicely, had the cute little purse and the stylish dress, and all. It didn't really fit.
Nails done,
Yes, it had a cell phone.
Yeah.
It didn't really fit the picture of, I can't afford a $1, or a 99-cent, little package of cough drops,
Gosh,
from wherever.
Dang.
But I thought, I might get fired over this one.
Is that really something that you could get a serious beef for in the hospital?
Probably. Yeah, I never have had one. I'm usually pretty careful about what I say to people, even if I'm upset. Yeah, you are professional.
You're not Dr. House running around telling everyone what an idiot
they are. No, although sometimes you wish you were.
Well, here's the part that I kind of struggle with on that is. One of the biggest frustrations I have when people talk about universal health care is that, it would be so much better if it was like Canada or the UK. Now, you've never worked over there, but you've had friends that worked in
Canada. Yeah. I also had a friend some years ago, and she had 7 brothers and sisters, watched every single one of them die of cancer waiting for treatment. And she told me then that anyone that can afford it leaves Canada and goes to the U.S. for treatment. So if you're young, if you're part of the workforce, if you're, in that age group, you'll probably get reasonably good health care in a situation like that. I've known younger people that were from Canada that thought the health care was just great.
Yeah.
Well, yes, because they were young and they were part of the productive workforce. But people that were older than 50, Not so much.
Yeah, now they're doing recommended
and that's
suicide.
not me saying that. That was a Canadian individual telling me that, and how horrible it was. And like I said, she's the one that said anyone who can afford it goes to the U.S. to get their health care.
It blows my mind when I talk to Americans about everything that frustrates them with American healthcare. I'm like, I get it. I'm not claiming our system is perfect. I'm not even claiming it's great, but I will say this: everything you're mad about within the American healthcare system is a result of government intervention into the American healthcare system. Right. And it is frustrating to watch how, and I've seen people within the medical establishment really co-opted by this idea that, like in telelaws or something, COPN, Certificate of Public Need. That's another thing that I talk to people about, where they don't understand that if you're in an underserved area, that doesn't mean someone can come in and just set up shop and start providing additional services. If you're a COPN state, they have to justify that there's actually public need. And part of the reason why they have to do that, or part of that process, is your competition in that area gets to say, oh, no, you can't do those particular services. And you say, well, that's ridiculous. How could that possibly be a thing? And it's like, well, if you're a hospital and you're taking Medicare and Medicaid, and then you have certain rules with respect to what you have to do, how much you can charge. You have certain services that you have to provide in an emergency room, which inevitably causes the cost to go up because of all the people that are getting services without paying. Whereas if you set up a clinic where all you're doing is paid services, you don't have the overhead associated with having to take people that can't pay for services. And so it's one of these things where you can understand why people are propping up a bad system. It's because they're scared to death of what would happen if those controls weren't there. But in the end, it really creates a perverse incentive. But I don't want to get too far off into the politics of it. What about, again, you worked ER, you're afraid to get fired on ER for people that were coming in that were abusing the system. Now we go to OB, and that's where you spent the majority of your time. So obviously there's something about it that you love, but I think a lot of people are probably looking like, OB, well, it's delivering babies, right? Like how, and you were saying that OB is the best and worst place to work. Explain that a little bit.
First of all, it's more stressful than Trauma ICU.
Wow.
I will definitely say that. It is a wonderful place to work. I love working in OB. Obviously, I've stayed there for so long, but it is also extremely stressful at times. You're responsible for a person that's right there in front of you, and then a baby that you technically can't see that's inside, and any number of things can happen, and they do. I have seen some incredible things happen over my almost 30 years of experience there. And, everybody thinks, and wants the perfect delivery, the perfect baby. Of course they do. And we do everything within our power to ensure that will happen. But there are things beyond our control. Just absolutely beyond our control. And as much as we try to, see inside, with different types of monitoring and things, it's not always something that you can fix or make right. As hard as we try. And most times things turn out okay. The minute you get pregnant, you've probably got somewhere in the neighborhood of a 25% chance of having a C-section. Okay. And I personally will try everything in my power to give you a regular delivery, the spontaneous vaginal delivery that you want. But thank goodness we can do a C-section if we really need to.
So I remember when Tina, and I've talked about this on the show. Tina's been here, and the first when she gave birth to Lily, that was a tough birth. The umbilical cord was wrapped around Lily's neck twice. She kept presenting and then disappearing, right? And then I'm trying to not be too graphic here, but it was. I remember us talking about this later, and you being a little bit frustrated with kind of how that went down, because you got to be there in the room with us, which I was very grateful for, because when Lily was finally born, she was blue, she wasn't breathing, she wasn't screaming, Tina was bleeding. I mean, it was a bad situation, and I was very, very thankful that you were there. And
I might add, it's a fairly common situation.
So is the umbilical cord wrapped around the neck like twice? Is that pretty common, or at least like what?
It's fairly common. Yeah. I've seen it up to 4 times.
And 4 times. Okay,
Yeah.
well, shoot, that's not
And
that common.
I've seen
this 30 years.
wrapped around the neck and what we call a true knot.
Oh, really?
Cord, where the baby has moved around so much that it has actually gotten the umbilical cord into a knot.
Oh my gosh.
And if that
is
tightens,
that like C-section?
No, you don't know it's there until the baby delivers.
Oh, okay.
I saw one of those recently too, and wow, it's you breathe a sigh of relief. Like, look at that, boy! If that had tightened up,
so what's
bad news?
And what's more difficult? So when a like we talk about the baby not being turned, we talk about the baby being, what is it? Breech is when they're turned around.
Breech is either feet first or their little bottom.
Okay.
Frank breech is coming out first.
Oh, wow.
That is not a great situation.
Yeah.
That is not good. If you know you're going to have a baby that's in a breech presentation, baby's not been able to be turned, do not try to have your baby at home.
Yeah.
If you know your baby is breech, you need to go to the hospital to have your baby and probably be a C-section.
Okay.
I had a situation at one place that I worked one time, and the people absolutely insisted on trying to, do a birth without having a C-section on their breech baby. And the doctor was there and everything, and the baby didn't make it.
Really?
They can get caught. Their head gets caught coming out, and you really are in a tough situation to try to get them out. And remember, you don't have that long.
Yeah.
You don't have that much time. And there was a situation where the parents absolutely insisted, nope, we're going to have this baby, vaginal birth.
Yeah.
We do not want a C-section. And
well, and look, I've become,
out.
I know 10 years ago, if you would have asked me about all this, I would have said it's stupid. Why would you do anything? Why would you do birth at home? Why would you do this? Why would you do that? And I've changed the way I've thought about a lot of this, and in some parts because of how frustrated I've been with the way the hospital system worked during COVID, with the way that pharmaceutical companies work. And so I've become a lot more skeptical and a lot more open to alternatives. But the bottom line is the bottom line. I mean, if you're talking about, so that's why the prenatal care is so important and understanding.
Important.
Okay. So you've got breech. You've also got, what is it? Face down or
face
up?
Face up when they're facing up.
Yeah.
Or facing outwards, like towards the front of you rather than your spine.
Yeah.
That's a lot more difficult to deliver as well. And some of those end up in C-section just because the baby's head is not made to mold that way. And it's a real tough one to get out. Really tough. Maybe even it's not that big a baby, but it's as if it were a 10-pound baby when it's a 7-pound baby. Yeah. And really hard to get out.
What's the heaviest baby you've probably delivered?
12 pounds.
Okay. Wow.
Yeah.
So what's average around 7?
7 to 8.
7 to 8.
Yeah, between 7 and 8 is pretty average.
So 12-pound baby, is that a fight?
That's a toddler. Yeah, it can be, and I've seen some difficult situations with things like that. The reason prenatal care is so important, coming back to that, is you could be gestational diabetic, in which case the baby will get a lot larger than average. You may have a lot more amniotic fluid than usual. And the baby will come out with its pancreas very confused because it's been relying on the mother's blood sugars. And then now all of a sudden that's gone. And it can cause a lot of issues. So that's one reason, just one situation where prenatal care is extremely important. Another one is if the mother's blood pressure is high. Yeah. A lot of people have high blood pressure during pregnancy or old age or whatever, and they're not even aware of it.
Yeah.
And that can be a very, very dangerous situation for the mother and for the baby. There are a lot of things that can go wrong with that. It can turn into, they used to call it toxemia years ago. Now it's called preeclampsia.
Yeah.
And the eclampsia part means seizures. And that can be a dangerous situation for mom and baby. It can also evolve into a stroke for the mother, an abruption, which is the placenta breaking away. There's a lot of things that can happen. So I would encourage everyone, please, please, please get good prenatal care. Mm-hmm. And, if you don't have the finances for it, you can usually be quickly accepted into like a Medicare, Medi-Cal, Medicaid, whatever your state has program where you can still get prenatal care. It's funny, I've had people come in and say, oh, I just couldn't get any prenatal care. No one would see me. And I'm thinking, that's funny because people come to this country, they don't even speak the language, and they get right in.
Yeah, yeah, yeah.
Where were you?
Yeah.
And usually it's because they're on some kind of drugs and they don't want to be discovered.
Yeah.
And that's becoming more and more common.
Really?
Yeah. People showing up, no prenatal care at all. They show up, they're in pain, they're in labor. We have no idea how far along they are.
Wow.
We may or may not have time to do an ultrasound to try to determine, depending on how fast they're delivering. We try to do quick tests to see what drugs they're on because that can affect the baby. There's just so many factors. And I've had numerous times with an ambulance pulling up to the back door of one of the hospitals that I work at. They're bringing somebody in and, we're just, working in the dark, doing the best that we can. And then, those people, of course, want a perfect outcome.
Yeah, yeah.
And we're flying blind. We don't know.
Do you think? I mean, obviously, there's a lot of kind of the litigious nature of society in general, but especially toward healthcare, where I remember when what was it, John Edwards was running for vice president with John Kerry, and you didn't like him much, not because of some of his political positions, but that too, but the fact that he had made a lot of money suing, You thought it, and again, it's obviously if somebody is genuinely guilty of malpractice or negligence or whatnot, that is one thing. But I remember you talking about there being situations where it was really, really easy because it's a horrible situation.
It is.
And you've got a jury that obviously already feels a great deal of sympathy for, the mother, the father. But it was really easy to manipulate juries into these large awards under situations that it was pretty dubious on whether or not the doctor had done anything wrong or the nurse had done anything wrong.
It was regarding primarily like cerebral palsy.
Yeah.
And what they've discovered through studies is that the effects of cerebral palsy oftentimes happen long before the birth event. And it's a silent thing. Maybe they got wrapped up in their cord or something. Most times it's never even determined what actually caused it. But
he was convincing him that it was doctors not doing C-sections quick enough, or
the doctor, the nurse, the hospital, whatever the case. And sometimes that is the case.
Yeah.
But probably many, many times it's not. So I didn't like him much.
Yeah. Well, and again, I think it's one of those things that people don't seem to understand is they'll talk about it. And look, I've carried legislation that will allow people to be able to sue hospitals, but it was within kind of narrow categories of, the hospital clearly was in violation of the law. Mm-hmm. This is how they were in violation of the law. The hospital had 30 days to correct. They refused it. But in this situation, it was almost like they were preying upon a very difficult situation. Yeah. And what that equates to is increased medical costs. Mm-hmm. And I think that's another thing that is sometimes missed out on this is that, okay, well, again, if someone got a large award and they were entitled to it because of what happened, absolutely, I understand. But none of this happens in a vacuum. This does impact.
Well, we've lost a lot of OB doctors.
Yeah.
Because the malpractice insurance is now so astronomically.
I've heard
high.
It's up to $100,000 a year.
I think it's even more in places.
Jeez.
It's so astronomically high they can't even afford it. So they have to go to work maybe under a hospital, like be employed by the hospital or that hospital system or something like that, in order to even do it. And a lot of them have left the practice. And maybe they love delivering babies, but there are things that are, again, there are factors that are unknown that we can't possibly know until that birth is happening or it's, already occurred or something occurred, early on, or maybe the patient didn't even get adequate prenatal care, or, all these things somehow that's our fault, if they don't get a perfect baby. And my heart goes out to those people. That's a terrible situation. Nobody wants that. And we do everything within our power to prevent those situations. But there are things beyond our control.
Sure. Well, and I think one of the things too that, because I think were you at all three of the births for, I think
Allie fooled me.
That's right. That's right. Allie.
I left work, got someone to take over my patients, jumped on an airplane, flew up to where you guys were, and they sent her home.
Yeah, that's right. And then shortly after, yeah.
And then I waited for a few days, told you guys all my secrets for going into labor. None of them worked.
Yeah.
So the day after I went home, of course, she was born.
She was born. That's right.
So I wasn't there for hers.
Yeah. Gosh. Well, I'll tell you. So let me ask you this. Kind of transitioning a little bit. So again, you've been a nurse for 45 years.
Yeah.
What was it like being a nurse under COVID?
Oh boy. Well, at first, I think we kind of didn't know what was going to happen.
Yeah.
You stop and you're trying to figure this all out, and you want to follow the rules, and you're trying to follow the best medical advice that's available at the time. And you kind of feel like you're, moving in the dark.
Yeah.
And so that was one thing that was hard. We'd have patients that came in, and I remember one patient, one of the first patients that I had to deliver, she had COVID. She was pretty sick with COVID, and she was in labor. She was 34 weeks, I believe, if I remember correctly. She wasn't my patient. I was covering for another nurse who was on a meal break. And all of a sudden, she went to deliver. And I have, the full isolation garb on.
Yeah.
And I'm pulling the alarm for help to come into the room because that baby is coming like right now.
Yeah.
I don't have a baby nurse. I don't have a doctor. It's just me and her and the baby daddy.
Yeah.
And people are trying to get all the isolation garb on, before they get into the room. So by then I've delivered this baby. And isolation gowns and all are not perfect.
Yeah.
So I was a mess, you know, and was exposed, in a lot of ways. And I'll tell you what, before I went home that night, I went in and took like a hazmat shower because we didn't know. I mean, it was all pretty new at that stage. And I remember telling my boss at the time, like, I got exposed. I had, blood all over me, and my gown had, slipped up and all these kind of things. Oh, no, that's not an exposure. It's a respiratory exposure. I'm like, well, if you really think that mask during that situation was, had me protected, I'm not so sure.
Yeah.
But, I weathered it, and I didn't come down with COVID. So that was nice. And the baby was okay. And the mom was a little in shock, but it was fine. And the nurse came back from her break and went, oh, my goodness. You delivered our baby. Yes, I did. Thank you.
And I remember it was funny because whenever you were there at the hospital, you always made sure that there was a gift basket for the nurse that was attending us and whatnot. And because it was funny, you're like, and you told me, like, you're like, sweetheart, I'll take care of it. You worry about Tina. Yeah. She goes, but I'm doing something for the nurses. And the reason why is because you're going to see this. The nurse will be there the whole time. The doctor will slip in maybe once or twice. And then at the very end, the doctor will come in to catch the baby, maybe. And then it'll be like, oh, thank you, doctor. And she goes, wait, what the heck?
Wait.
So we were always sure to make sure that we were thanking our nurses. So you're working during COVID, and obviously as things start to develop, then all of a sudden there's don't worry, we have a vaccine.
Yeah.
And obviously you're working in arguably one of the most dangerous places that for
high risk.
Yeah, high risk for infection and whatnot. What was because I know how Tina and I felt about it. And Tina and I we're not anti-vaxxers. Like we don't believe that vaccines are all bad or anything like that. However, we're cautious about them because we understand, like anything else, things are designed, things are manufactured, things are administered by people. And not everything always works as advertised. And we don't know absolutely everything there is to know. And I remember we took a lot of heat when our kids were little by kind of extending out some of that process. And we would say, well, no, we don't want 20 vaccines for our kids all in one sitting. And we had doctors roll their eyes at us. We had, and again, I'm not telling other people what to do, right? This is an area where I don't claim to be a subject matter expert. I know what we knew at the time. I know what we had experienced with other family members and their situation. And we said, you know what? This is the decision we're going to make for our children. And so we just kind of extended out the schedule and waited on certain things. And that still got, doctors looking at us like we were idiots or witch doctors or whatever else.
Yeah.
When this came out, when the vaccine came out, Tina and I pretty much right off the bat said, there's something we don't trust about this. And as we looked at what COVID was doing, because obviously if you're talking about March of 2020 or whatever it is, we didn't know, was this going to be the worst thing ever and wipe out a third of the population, or was it going to be what it turned out to be, which was, bad, but we weren't in a high risk, range, and our kids, we didn't have a bunch of comorbidities. We didn't have a bunch of other issues. We weren't elderly. We didn't have respiratory problems. And we were both a little bit concerned with how quick this vaccine came out. And then we were a little bit concerned with the fact that it didn't seem to be working as advertised. And I'm old enough to remember if you wear a mask, this, and if you take this, and if you do this, and then all of a sudden it was, okay, but that isn't working the way you said it was going to work. And then it was, but now trust us. The experts are now telling you to take this vaccine. That's going to work fine. And there's no real side effects, and don't worry about it. And my attitude, quite frankly, was screw you. You've told me a bunch of other crap that didn't turn out to be true, and I don't know if I trust you on this. And because there's about a 0.03% chance that this could kill me, I'm not taking your vaccine. Now, that was fine for me. I didn't have a job that was going to fire me if I didn't take it. You did have a job that was potentially going to fire you. What was your...
I knew nurses that got fired.
Yeah.
And I knew nurses that were threatened. If you do not get this, you will be fired. And they were just agonizing over the decision. It was a horrible decision for them to have to make. I never did get the vaccine.
Yeah.
I caught COVID 3 times.
Yeah.
The first time, I felt pretty lousy. It was like having a flu.
Yeah.
Body aches. I think I had a fever. Did have a fever for a day. Sore throat, headaches. I felt pretty lousy. And then you felt really tired and weak for, a week or two afterwards. And I remember that there were certain people that I knew that were in high risk categories. My own mother was, well into her 80s, and she decided, after looking at information, that she wanted to go ahead and get the vaccine because she had not good lungs, not a great heart, and she was like 84 years old.
Yeah.
So she decided to go ahead and get the vaccine, and I didn't try to stop her from that. We were still in a phase where we really didn't know, and you were hearing stories about all these people that died from COVID, and that hospitals were pulling up, semi-trucks and loading it with bodies. And yet, on the other hand, there were like MASH hospitals set up that never got a patient.
Yeah.
Like, what's going on here?
Yeah.
And I started really feeling like, wow, there's a real mixture of information here, and I'm not sure what's accurate. Are they kind of cherry picking their information? What's going on? And yet there were nurses that caught COVID from taking care of patients that died. So there was a lot of confusion, I think.
So why didn't you want to take it, and why didn't you get fired for not taking it?
Okay. I was already on record for my religious beliefs for stating that I would not take part in any abortions whatsoever. So I was already on record for that. There was information that the vaccine had been made by using DNA and things from
stem cells
and from aborted babies.
Yeah.
And that was the kicker right there. Is I want nothing to do with that.
Yeah.
So I wrote up, they asked us to write an explanation of why we were declining the vaccine. And I wrote this up, and I explained my religious beliefs and that I was on record for not participating in abortions in any way. And I got an initial okay, we'll kind of let it slide for now kind of thing. And then a couple months later, all of a sudden I got another notice that it was under review, and it was almost like you're going to have to do better than that.
Yeah, yeah.
Kind
Not
of
a good enough explanation.
Not a good enough
religious
explanation.
conviction.
So sat down with a friend of mine and tried to explain more fully, the depth of my religious experience and beliefs and my commitment to that. Things like when my children were young, I took them out of school and took them on mission trips and things that I've been a medical missionary on a number of occasions, that I have refused to take part in abortions on, every occasion. And they finally said, okay, all right, we won't hold you to it. Another person I know, one was a pastor's wife.
Yeah.
And they said, nope. Get the vaccine or you're fired, and they fired her.
Wow.
And another one that her commitment is known to everybody. How the strength of her religious commitment, and she was told get it or you're fired. And she was at that time like the main income for her family, and was just distraught over the decision, but finally went ahead and got the vaccine, and just agonized over it. And I tried to really encourage her and just say, look, you made the best decision you could at the time.
Yeah.
You did what you felt you had to do for the sake of your family. Don't beat yourself up. And then there were people that really were afraid. Maybe they were diabetic, or maybe they were, overweight, or maybe they had a history of asthma or pulmonary compromise or cardiac compromise, that felt, I've got to get this. And I held no judgment towards anyone for getting it. But my personal decision for myself was that I don't want any part of it. I don't want to take it. And then as time went by and you started hearing about cardiac complications, people with massive blood clots, a friend of mine ended up after taking the booster with massive blood clots. This is a very healthy young woman, very active. And she had a blood clot that extended like from her knee to her thigh. She could have died from that. You start hearing stories from undertakers saying that never have they seen anything like this, with people with massive clots, like, feet long clots in their system after having, and they, it turned out they were people that had taken the vaccine. So really a lot of information here now that we didn't have before. Yeah.
Well, and what's crazy to me is that I've had a number of people. What was fascinating to me was how quickly the quote experts, right? The government approved experts, because that's what it was. You weren't hearing from all the experts. You were hearing from government approved experts, because they were working with Twitter and Facebook and everyone else to shut down anybody that was dissenting from the CDC narrative or the Fauci narrative. And it was amazing to me, the number of people that just kind of went along with this. The same people that would have been skeptical of the government 5 seconds ago, all of a sudden in this situation is, nope, whatever they tell me is good, inject me up, give me another booster. And again, my whole attitude was, if you want to get it, I'm not telling you what to do. Like, do what you think is best. I'm not trying to make the decision for you, but I'm going to make the decision for me. And I'm not going to be ridiculed for it, especially under, everything that we've now kind of learned. And it's fascinating now how the same hospitals that were complaining about a nurse shortage, it's like, oh, you mean the ones you fired, the perfectly qualified, perfectly good nurses, the one that were willing to come in and get tests every 3 days to stay employed?
And that's what I had to do. Get tested every 3 days.
You fired them. And here's the other thing, the other part of COVID that I don't think we've fully captured or probably ever will, was the number of people that died because they were not just for, mental health issues or alcoholism or suicide, but the number of people that died because they weren't able to go in and get care for the things that they needed as a result of hospitals prioritizing everything toward COVID. And you look at it later, it's like, this wasn't even the most deadly thing that was affecting people. And again, the frustration, I remember talking to, we talked to another friend of ours, and her whole job is, and again, won't say any names or whatnot, but her whole job is working in this particular field. And I remember asking, are you getting it? And again, she fights viruses is what she does. Are you getting it? And she goes, I'm not getting it. I'm not having my children get it. She goes, I will tell my elderly parents that I think it makes sense. But what was she doing? She was looking at the available data that we had. She was looking at everything that we knew about it. And what it came down to at the end of the day was, if you're in one of these categories where this has a much higher degree of probability of potentially killing you, negative side effects of the vaccine probably won't be as great a threat to you as this. And what was amazing was when she sat there and explained it was completely dispassionate, cost-benefit analysis based off of available data. There was none of this, well, if you don't take this, you're a bad person. You want people to die. Or if you do take this, you're a simp for, whatever. It was just dispassionate analysis, which is what I was looking for, which is what I think so many of us were looking for during that time, and just had it utterly refused to us. But that had to be an incredibly hard situation to be working in an environment where, again, it wasn't a hard stand for me to take because I wasn't running the risk of losing my entire income as a result of it, or losing, a 40-year career at that point.
Yeah. The other thing that was frustrating, I think, was anyone that passed away from any reason whatsoever, if the hospital said they tested positive for COVID, it was listed as a COVID death.
Yeah.
And I know somebody that had severe heart problems and also had leukemia and was well into their 80s. Actually, I think he had turned 90. Yeah. And when he passed, they put down that it was a COVID death, and his daughter was livid, just furious. Like, that is not why he died. He would roll over in his grave if he knew that they called his death a COVID death.
Well, the joke is that someone shows up with 3 gunshot wounds. Oh, but they also tested positive with COVID death. And
don't laugh. I think that was true.
Oh, well, and inflated, and people ask, well, how could they get away with that? It's like, well, this is also the thing I try to explain to people.
Follow the money.
This is also the thing I try to explain to people about government policy. When the government is handing out money, people start looking for what conditions get you the money.
Right.
And the conditions that got you the money during COVID was COVID death. Well, how are you going to prove it one way or another? Well, the government didn't want to say, well, you got to prove it was a COVID death. They just want to say if they tested positive for COVID and they died in the hospital, there you go, it was that, and you could get the money. Well, okay, so now you've created a perverse incentive to actually inflate deaths related to this, but then the deaths inflated to get the money is also what's fueling the money and the policies and the regulations. And that's why it is so dangerous for the government to kind of take the position that it does during some of these issues. It's not because the government doesn't have any role to play. For instance, I thought it made a lot of sense when we restricted travel, international travel, especially from China, right? And I thought even though that was racist and mean, and then I thought it made a lot of sense initially for the military to be deployed, to be able to say, the National Guard deployed, they set up these MASH hospitals, like you said before, in order to deal with overflow. But then when
that didn't get used.
Then when it wasn't needed, but then at the same time, you got people like, Cuomo pushing people back into nursing homes.
Yes.
And the argument was, well, they've got no place to stay. I'm like, well, no, that would have been a good use for your MASH hospitals. That would have been a good use for some of these other things, rather than pushing them right back into this environment. But well, look, I want to. There's 2 other things I want to get to here. One is being a nurse in the mission field. So I remember when I was little, you took us to the Philippines, you took us to Okinawa, you took us to Mexico. The colonias had flooded really bad in Tijuana, and you brought JW and I down there with you, and we would kind of like entertain the kids waiting in line and play games with them and stuff like that while they came in to sign. So what was it? What was it like being a nurse in the mission field, and what would you say were some of the most difficult conditions you've ever seen overseas?
Oh boy, the abject poverty that you see when we were in the Philippines. Average annual income was the equivalent of $300. Yeah. For an entire year. These people just had to fight to keep from starving to death. And I think one of the most impactful things that we saw, and I remember you and your brother reacting to this, was when they took us down to what they called Smoky Mountain in Manila. Now, if you ever saw Slumdog Millionaire, and they show people living in these massive garbage dumps, trying to live there, trying to find bits and pieces of something they could actually eat, or something that they could trade off, like a Coke bottle or whatever, get a couple pennies for, or whatever the currency, to buy a handful of rice just to survive. And when we were in Manila, I believe they said that the population in Smoky Mountain was somewhere around 100,000 people. It was huge.
Oh, in Manila was Smoky Mountain. I think they said I can't remember how many thousands of families they said there were. They didn't have an accurate count, but it was a lot. And it was, I also seem to recall them talking about, they had various plans to kind of like relocate people and put them in like basically their version of affordable housing. Yeah. And people didn't want to leave because it was the source of their income. Yeah.
They had no income.
Yeah.
And I remember you and your brother reacting because there's the garbage spilled out into the ocean, tons and tons of garbage. The kids were out there swimming in it.
Yeah.
And I remember the looks on your faces, and one of you grabbed my arm just tightly and said, "Mom, look, they're swimming in it."
Yeah.
And it was really, really a tragic situation. The group that we were with was actually trying to work with the government to bring clean water and vaccinations to the people, the kind of vaccinations that
smallpox, polio.
Yes, that were proven, you might say, to prevent life-threatening diseases and things. So that was some of the wonderful things that group did. That group was working with young girls that had been, in many situations, sent by their families down to work in the bordellos, the
brothels.
The brothels. And that was a sad situation. Some of these girls were very young. And what our group was trying to do was go in there and kind of rescue these girls out of sex trafficking, basically, and teach them how to be seamstresses and give them jobs. And they had they'd been taught how to like make wedding dresses. And there was an outlet, I think over in Europe, that they had for these. And, some people might look at that and say, oh, all you did was create a sweatshop or something. But it's like, no, what the group was creating, they didn't just come in there and say, hey, receive Jesus and, go, be filled and healed and walk away. Yeah. They were creating a way for these people to actually support themselves in a reasonable fashion on the income, on the economy that existed in that country at that time. Yeah. In that time and place. And that's what people sometimes don't understand. Oh, you might go, well, we want to shut that down. It's a sweatshop. Well, no, it might be the only source of income they have other than prostitution. And they were actually working with these gals to get them a reasonable, decent living wage and get them out of sex trafficking. Yeah. And also it was a really wonderful group that we had gone with. We ended up way up in the mountains working with people that lived up in a tiny village that we had to hike into. And that was a great experience.
I was watching one of these list channels on YouTube, and it would be like top most dangerous like rivers or top most, and then one was the top most dangerous roads. And I'm watching it with Tina. I'm like, oh my God, my mom, brother, and I were on that road in the Philippines in Luzon. And it was like the highest point on the Filipino freeway system. And I remember like riding on the top of a jeepney for part of it.
I remember being on some kind of bus or something, one direction or the other going across that bridge and looking down. And it was like, oh, Lord, please. Get us through this. Yeah. I can't promise to be a missionary. I already am one. But it was quite an experience, and the people were just so loving and so dear that we went and worked with, and it was a great experience.
Well, let's the last thing I wanted to talk about is, we talk a lot about self-reliance on the show, and we talk a lot about people that, being more resilient, and the idea of it's not about isolating yourself in the middle of nowhere, not having it. It's just about having skills, knowing what you should, be able to do. And, we have fun with it. We joke around about zombie apocalypse and things like that. But bottom line is you never know when you're, a skill set which might be really, really valuable for really, really bad situations is still valuable if you're going hiking with your family.
Exactly.
Right. On Shenandoah National Park and you're miles away, right? Yeah. You might be camping. You might find yourself in a situation that you didn't anticipate. All of a sudden somebody falls down or they get bit by a snake or whatever it is. So what I want to do now is I want to talk a little bit about like what are some of the medical skills that are fairly easy to learn, right? That everybody should know. Yeah. Like what's like, give me your top 3 or so.
Yeah, probably the number one. I would encourage everyone go take a CPR class.
Yeah.
Go get CPR certified. They will teach you the proper way to do it. What's most important. It's a relatively easy thing to do. And I just think that is incredibly valuable. I would really recommend that one, first of all.
We had a situation where we were eating, we were out eating.
Oh, yes.
And Allie was really little at the time, but she started choking on a piece of like mozzarella stick.
Yes.
And I'm sitting at one part of the table, and then I look over and I see Tina first, and Tina's just like, pointing over at Allie, and Allie's choking. So I got up there and did the Heimlich real quick, and it, that kicked out. And then I went over and I sat down and I just started eating again. And and Tina did this long post about like, this is one of the reasons why I love my husband, and he makes me feel safe and he makes our kids feel safe. And I remember thinking like, I remember my mom teaching me how to do this when I was little, mainly because like I'd choke on a hot dog or something. And, but that's another reason how to learn not only do CPR, but like the Heimlich maneuver and stuff like that is because women find it super impressive when you jump up in a
save
situation.
A life,
All right, so CPR.
It's a great way to pick up chicks, right?
Yeah. So CPR, Heimlich maneuver. What's another?
Another thing is stop the bleeding.
Okay, yeah.
If someone is injured, regardless, a knife wound, gunshot wound, fall down, it can be just about anything. And they've got either a cut or a gash or a large abrasion. It could be a number of things. Stopping the bleeding is an important one. And the main thing you do is just apply direct pressure.
Okay.
That's probably the most important, most basic thing that you can do until you can get to a healthcare facility, a higher level of care to where they're going to be able to stitch it up or whatever's needed, cauterize. And it just depends, like where you are, how far you are from a facility that can help you with that.
Yeah.
You might be out in the woods hunting and somebody's gun goes off unexpectedly, or their knife, they get a knife wound or they fall down.
Yeah.
And they get, cut pretty badly on a rock or something, then you would need to know how to do that. You might need to know how to close the wound. You might be able to take something stretchy and wrap it around an arm or a leg or something.
Yeah. I remember it was funny. When I first went into the military, there was, obviously they took us through, and I went through EMT training at the time. So I was an EMTB for a while, EMT basic. And it was interesting how initially I went in 98 and there was all this assessments that you did and then by the time I was going to Iraq, it was stop the bleeding. Like that is your number one thing, stop the bleeding. Because if you could get them, we found that if we could stop the bleeding or we could slow it significantly and we could get them to a field hospital, it was something like a 90% survival rate.
Yeah.
I mean, it was crazy. But if they bled out, there was just nothing you could do.
More you could do.
And the things they would focus us on is like packing the wound. And you got to figure obviously infection is always a concern, but the thing they emphasize to us is that it is, you're not worried about infection if they bleed out.
Right.
And so stop the wound, and they would have us, they gave us, like, we had little packs where we could put like sanitary cloth in there and pack it to try to reduce infection. But if you're in a really bad situation and stuff's going off and there's dust in the air and everything else, I mean, it is what it is. And then applying a tourniquet. And that was one thing that, a tourniquet, they said was kind of a last resort, because you got a tourniquet applied too long, you're losing something, right? That limb's coming off. But if you had arterial bleeding, you're applying the tourniquet as best you can. So CPR, Heimlich, stop the bleeding. What's one more? Give us one more that would be just good to know. When you said close up the wounds, like obviously not most of us don't know how to do stitches. But if you had to do something to close
a wound, first of all, you're going to want to try to clean it the best you can.
Yeah.
If you've got a bottle of alcohol of some kind, probably not rubbing alcohol. It's some other kind of alcohol.
Yeah. If I'm going camping, Mom, I probably don't have a lot of rubbing alcohol, but I might have some. I might have some other. So if I've got
take a good swig yourself.
So does that really work though? If all I've got is Jack Daniels, is that still better to put on the wound than nothing?
It'll wash
at all?
it out. I don't know if it'll do anything to sterilize it. early, to tell you the honest truth.
All right.
But you want to stop the bleeding. You want to try to close the wound. If you have needle and thread, I mean, you could try to do just a simple stitch to close the wound.
Yeah.
Or
Super
applying
glue.
direct pressure
Yeah.
to a wound is another way. Splinting, if there's a broken bone and there's bleeding,
Yeah.
you can use almost anything that's reasonably straight and wrap to try to splint a wound, splint a bone, and stop the bleeding.
Yeah. Now, what about airway? What if I got to do a trach?
Okay, well, watch a video.
Yeah, they taught us how to us how to do that. Where it was two things they were looking for, because we were looking, a lot of the stuff we were talking about was GSWs, right? Gunshot wounds.
Yeah.
And so it was, if you had the chest cavity filling up with air and you needed to relieve it, they were like, okay, you want to go to the third and fourth intercostal space, and that's where you would stab in to allow for the air to release, so it didn't crush your lungs and basically suffocate you.
And pray.
Yeah. Same thing with like where to go in order to clear up the airway. But again, we're not saying go and try this on your buddy right now. We're just saying
don't
survival.
try this yourself at home.
Yeah. All right. And now the last question I want to ask, emergency situation, again, for the guys out there that want to look cool, just get your wife to the hospital in time to have the baby. But all right, but as promised at the beginning of the show, all right, I'm there. I'm with my wife. We are driving. We live out in the country because screw the city. And oh my gosh, she's going into labor 2 weeks earlier than anticipated. And as we're taking the 45-minute drive to the hospital, baby's coming in the back seat, and again, all I've got is me, my trusty pocket knife, AC/DC's greatest hits, and a bottle of water. How am I delivering this kid in the back of the car, Mom?
This actually happened to my cousin.
Oh my gosh. Okay. All right.
She very successfully had a baby in the backseat of a car on the way to the hospital.
So AC/DC's Dirty Deeds Done Dirt Cheap.
Yeah, I don't think they were listening to that.
Okay. All right. So, but what are the basics you need to know for the scared young father trying to catch a baby, or for the scared young mother that did not anticipate this was not in the what to expect when you're expecting, but
true.
Right.
Honestly, if the baby's coming that quick and easy, they kind of deliver themselves.
Really?
Just about. If they're coming out that quick and that fast, they just come right out usually. In a car, it's a little awkward because of the positioning. If you know that you're not going to make it, you probably want her in the back seat of the car. Just get out and get in the back seat. What you're going to do is you are hopefully going to see a head first. Yeah. If you don't, then just keep going to the hospital.
Okay.
Probably. But you're probably going to see a head first. And then what you're going to do is you're going to actually bring the head down so that the upper shoulder will come out from under the pubic bone and deliver. Then you lift up, and then the lower shoulder will hopefully slip out. Yeah. And then put the baby, wet and messy, right up on the mom. Try to dry the baby off, and just put them up there, skin to skin with the mom. Wrap them up. You want to keep the baby as warm as possible. You don't want that baby to get cold. And it's like when you step out of the shower all wet, you're going to get cold immediately. Yeah. So you want to try to dry them off, put them skin to skin with the mom, wrap them up with anything you've got, your coat, your shirt, the mom's shirt, anything you have.
So what is so important about skin to skin contact with the mom?
For one thing, it's calming to the baby.
Okay.
It's a very calming thing. The other thing is that the body heat from the mother helps keep the baby warm.
Yeah.
You don't have to worry.
Yeah. I know I like to be skin to skin contact with my kid's mom. That's okay. So I'm not supposed to be making these jokes with my mom. Okay.
Hey, I've been a nurse for 45 years.
Yeah, I got
not a whole lot that can shock me these days.
I didn't get the talk from Dad. I got the talk from Mom. And when your mom's an OB nurse, the talk is, I imagine, different than when most boys got. But okay, so the baby's delivered. So I'm not trying to cut the umbilical cord. I'm not trying to do any of that.
No, you don't want to cut it, but oftentimes the placenta will deliver relatively quickly afterwards. Okay. So usually you have enough cord, you could bring it out and tie it in a tight knot.
Both sides or one side?
Just one tight knot.
Okay.
Yeah, because you're not going to cut it. You're just going to get to the hospital at that point.
Okay. And then the reason why you don't cut it is because the baby or mommy can bleed out from that, right?
Right. You don't want to just cut the cord.
Yeah.
It's got to be clamped off. But you're not going to have cord clamps with you probably in the car.
No.
So you just want to tie it in a good tight knot.
Okay.
And then if the placenta delivers, it delivers.
Okay. But if it doesn't, it's okay to stay in there if I'm driving?
Yeah. If you're on the way to the hospital, hopefully you're not too far away.
Okay. What happens if I'm snowed in at the cabin? So now it's like I gotta get a couple of zip ties and like
zip ties, thread, a little piece of cloth or whatever, and go a little, closer to the baby's umbilical, where the umbilical
belly button
cord attaches. Yeah. And tie that off so that the blood can't back out. And then then what I would say is like kind of strip it away from the baby a little bit, tie another knot and cut it right there.
Okay.
Now, hopefully your placenta is delivering relatively quickly. When the placenta comes out, then you want to go in right about by the mother's belly button, by the umbilicus. And you're going to want to massage that. You're going to want to rub it, not in front, but like literally the top of it.
Okay.
So you're going to go down in and rub that. That helps the uterus to clamp down and tighten down and helps control the bleeding, because there's a lot of bleeding that goes on after that placenta detaches and comes out.
And when the placenta delivers, you're going to know it, right?
Oh, yes.
Yeah.
You'll know it.
Okay.
She'll know it, too.
Okay.
It's pretty obvious. It's pretty good sized.
Okay.
And
don't eat it, you weirdos. Oh, my gosh. People that eat the placenta, like, oh my God.
If you got to do something, go plant it by a tree.
Right? Yeah, maybe. But like, you're basically eating your kid's clone. It's weird. Don't do that. Don't do that.
There are people that do.
Yeah. Don't appropriate cannibal culture. All right.
And there's people that want to take their placenta home with them. Here you go.
We did it.
It's all yours.
We're like, that's yours. That's a special gift we left for the hospital.
Yeah, no, thank you.
All right. So if you can get to the hospital, get to the hospital. If you can't get to the hospital, deliver the baby, dry off the baby, make sure you can sweep the airway if they're not.
Yeah.
Okay.
Yeah,
But skin to skin. So baby's crying now. Skin to skin contact with mom. Mm-hmm. Mom's in the back seat. I haven't, and at that point, I'm not cutting the umbilical cord. I'm 20 minutes from the hospital. I'm just going to get to the hospital and let them take care of that there.
Yeah, but tie a knot in it.
Okay.
Tie a knot and hang on.
All right. But if I'm snowed in at the cabin, I'm going to get some threads, some ropes, and whatever I can. I'm going to tie it close to the baby's belly button.
Pretty close, yeah.
And then what, like a couple inches?
Yeah, then leave another couple inches, tie it off again.
And cut
it. Yeah. You better tie it off on both ends, because then when you cut it, it's going to make quite a mess.
Okay.
So, tie it off, maybe an inch away from the baby, and then go a couple inches, kind of strip the blood toward the placenta away from the baby after this has been clamped.
Yeah.
Tie that off and then cut in between. And now you're going to prevent some of the mess.
Okay. And then the placenta will deliver, and then it's just about kind of monitoring to make sure mom's doing okay, baby's doing okay.
And that's in a fairly ideal situation. The placenta delivers and all that.
Okay.
We won't go into other emergencies
at
that point.
All right. Well, good news. If you listen to this segment, you are now an OB nurse. That's right. That's all.
No, there is a lot more to it than that. No way.
All righty. It turns out there are some more things you have to do. So don't go rushing out. Don't go rushing out telling pregnant women you can deliver their baby to try to look cool, guys. All right. It's just, it's not
a good way to impress your girlfriend.
No.
Or anybody.
Yeah. All right. Well, Mom, thanks very much for coming on and sharing.
It's my pleasure.
Sharing some stories with us. Oh no, it's been a blast. Hopefully you have learned a lot. Again, we're not telling you to go out and try this at home, but if you ever do find yourself in a survival situation, now you know the skills that you should get ahead of time, right? Go learn CPR, go learn the Heimlich maneuver, learn how to effectively stop bleeding, and again, don't if your wife is about to give birth, like you're a couple weeks out, maybe hold off the camping trip. But if you just insisted that, like, if she just needed to go camping, and then all of a sudden now at least a couple of things that you can do either in the car right there or in the snowed-in cabin, although that's not ideal. We're not advocating this, right? This isn't advocacy for that. But once again, thank you all very much for joining us. I hope everyone is having a great Christmas season with their families. Thank you once again to Good Ranchers for sponsoring this. Again, it would be hard to do this show if we didn't have sponsors like Good Ranchers that were willing to come in and advertise with us. And so if you are looking, they got some great deals going on. Go to goodranchers.com, use promo code Nick. Some of those deals go all the way to December 31st. All right.
Oh, wow.
So check that out. But once again, thank you very much for joining us, and we'll see you next episode.